Welcome to this case presentation involving a 33-year-old male who presented to the hospital with severe back pain. After thorough investigation, the final diagnosis were determined to be a vaso-occlusive crisis due to the sickle cell disease. This presentation will allow you to see the clinical picture from the patient's history and presenting symptoms to diagnostic workup, differential diagnosis, and final treatment plan. Sickle cell disease is a hereditary blood disorder primarily affecting individuals of African American descent and is associated with recurrent pain crisis due to occlusion of small blood vessels by abnormally shaped red blood cells. This particular case is significant as it highlights the challenges in managing chronic diseases like sickle cell, especially in younger adults who may present with vague or overlapping symptoms. Through this discussion, we will review the relevant clinical guidelines, interpret results, and consider the appropriate course for management to improve patient outcomes. The patient is a 33-year-old African American male who presented to the emergency department complaining of severe generalized back pain that had persisted for 4 days. He reported that the pain was deep, constant, and rated a 9 out of 10 in intensity. The patient described a similar episode just 1 week prior, but he was discharged and evaluated from a nearby facility. Importantly, he denied any recent trauma, fever, cough, or urinary symptoms. He also denied any new medication engaging in strenuous activity. Over the counter analgesics had not provided any relief, nor has his oxycodone prescription. His pain, described as radiating and non positional, significantly affecting his mobility and daily functioning. These details suggest a systemic cause of pain and should prompt providers to think beyond musculoskeletal etiologies. A thorough history is essential to rule out red flag symptoms and determine the need for further diagnostic evaluation. Patient past medical history is quite significant and aligns closely with presenting complaint. He has a known history of sickle cell disease, specifically the homozygous hemoglobin SS variant, which is the most severe form of the disorder. He also has a history of cholelithiasis and underwent a cholecystectomy in his early 20s, which is a common complication of chronic hemolysis in sickle cell patients. He suffered from acute chest syndrome at age 25, indicating the severity of his disease. He has no known drug allergies. His current medication includes hydroxyurea, a disease-modifying therapy known to reduce the frequency of pain crises, and folic acid, which supports red blood cell production. He also occasionally uses ibuprofen for pain, as well as his prescription medication, oxycodone. Knowing the patient's medication compliance and previous complication provides important context of evaluating whether this is an isolated crisis or part of a severe disease pathway. On physical examination, the patient appeared visibly distressed due to pain. His vital signs revealed tachycardia at 108 beats per minute and at a slightly elevated respiratory rate of 22 breaths per minute. Both consisted of systemic pain and possibly early hypoxia. However, he was afebrile, which made infection less likely at this stage. Blood pressure was stable and oxygen saturation was 96% on room air, indicating no immediate respiratory compromise. Musculoskeletal examination showed tenderness over the thoracic and lumbar spine without deformity, muscle spasm, or signs of trauma. Cardiovascular examination revealed tachycardia but a regular rhythm without murmurs. Lung auscultation was clear bilaterally, ruling out acute chest pathology for now. For neuro, he was alert and oriented with no focal deficit, ruling out cord compression and other neurological emergencies. This physical exam supports a systemic hematologic cause of pain rather than a localized musculoskeletal or infectious process. The diagnostic workup provided valuable clues supporting a diagnosis of vaso-occlusive crisis. A complete blood count showed a hemoglobin level of 7.8, indicating moderate anemia, along with leukocytosis. which could reflect stress, inflammation, or early infection. The retic count was elevated at 7%, consistent with a comp- compensatory marrow response to ongoing hemolysis. LDH and indirect bilirubin levels were both elevated, further supporting intravascular hemolysis. A peripheral blood smear revealed sickle red blood cells, a hallmark of sickle cell disease. Chest x ray showed no acute abnormalities, ruling out acute chest syndrome at this point. Urinalysis was within normal limits, helping exclude pyelonephritis or renal calculi as the source of pain. These findings, in the context of known sickle cell disease and severe pain, strongly point towards a vaso-occlusive crisis as the primary diagnosis, warranting prompt management to prevent further complications and readmission. When evaluating a young adult with severe back pain, a broad differential must be considered. Musculoskeletal strain is common, especially in active individuals, but this patient had no history of trauma or relief with NSAIDs or oxycodone. Pyelonephritis was considered due to the location of pain, but he was afebrile with a normal urinalysis. A spinal epidural abscess could present similarly, but he had no fever or neurological signs. Acute chest syndrome, a life threatening sickle cell complication, was considered due to his history, but current imaging and respiratory assessment were unremarkable. Ultimately, the most fitting diagnosis was vaso-occlusive crisis. The patient's past history, lab findings, including elevated reticulocytes, LDH, and sickle cells, along with the absence of other alarming findings, support this diagnosis. Differentials were essential to rule out urgent conditions, but the clinical picture clearly aligned with a sickle cell related pain crisis requiring immediate supportive care. The final diagnosis for this patient is vaso-occlusive crisis, VOC, which is the most common complication of sickle cell crisis. VOC results from the obstruction of blood flow due to sickle cell and blood cells, due to sickle red blood cells, leading to ischemia and severe pain. The diagnosis was confirmed through a combination of clinical presentation, past medical history, and supportive laboratory findings. Elevated reticulocyte count, LDH, indirect bilirubin, and the presence of sickle cells on a peripheral smear all pointed to active hemolysis. The patient's prior episodes, especially his history of acute chest syndrome, also suggested that he has a more severe phenotype of sickle cell disease. This diagnosis underscores the importance of recognizing pain crisis early to prevent life threatening complications. Moreover, this case serves as a reminder for the systemic nature of sickle cell disease and the need for comprehensive management that goes beyond treating pain alone to include prevention and long term care. Algorithm of VOC management. Manage a vaso-occlusive crisis involves a structured and evidence-based approach. First, immediate pain control is critical. Opiates are typical use, often in combination with NSAIDs, to address both um, nociceptive and inflammatory pain. Second, adequate hydration is essential to reduce blood viscosity and prevent further sickling. Intravenous fluid, preferably isotonic saline, are administered carefully, especially in patients with renal impairment. Third, oxygen supplementation may be needed if the patient is hypoxic. Providers must also investigate and treat potential triggers such as infection, which can precipitate a crisis. In severe cases, blood transfusions may be necessary to reduce hemoglobin S levels and improve oxygen carrying capacity. The algorithm should also include monitoring for complications like acute chest syndrome, stroke, or multi-organ failure. As shown in the algorithm on this slide, early intervention is vital to break the cycle of pain and prevent readmission, making this structured plan crucial for patient safety. The acute treatment plan for this patient focused on pain relief, hydration, and supportive care. He received IV morphine at appropriate dosing intervals along with NSAIDs and oxycodone. Isotonic IV fluids were initiated to promote hydration and reduce sickling. The patient's oxygen saturation was monitored and supplemental oxygen was kept on standby just in case of desaturation. Series of vitals were taken. Labs were used to assess for early complications like acute chest syndrome or worsening anemia. Blood transfusions was not immediately indicated, but a typing screen was completed. For long-term management, a review of his hydroxyurea dosage was recommended to optimize its disease-modifying effects. Patient was referred to follow up with hematology for ongoing care coordination. Education on recognizing early sign of crisis and maintaining hydration was reinforced. This treatment approach was aligned with current guidelines and aimed at both resolving the acute crisis and preventing future ones. Patient education is an essential component of managing chronic illnesses like sickle cell disease. During his admission, the patient was counseled on the importance of medication adherence, particularly with hydroxyurea, which has been shown to reduce the frequency of crises and hospitalizations. He was advised to maintain adequate hydration at all times, avoid extreme temperatures, and recognize early signs of pain, crisis, or complication like chest pain or neurologic systems. The patient was also informed about the importance of routine follow up with his hematologist and primary care physician to monitor for complications such as avascular necrosis or chronic kidney disease. Psychosocial support was offered, as patients with sickle cell often experience chronic pain and may benefit from cognitive behavior therapy or support groups. A pain management plan was created for home use, and social services were consulted to help coordinate future care. This comprehensive approach aims to empower the patient and prevent readmissions. Prognosis for patients with sickle cell disease varies depending on disease severity, access to care, and the presence of complication. This patient who has already experienced acute chest syndrome had recurrent pain and recurrent pain crisis is at increased risk for long-term complications such as avascular necrosis, stroke, pulmonary hypertension, and chronic kidney disease. Regular follow up and adherence to hydroxyurea therapy can significantly improve life expectancy and quality of life. Psychosocial factors also influence prognosis, as chronic pain can contribute to depression and social isolation. With optimal care, patients can live into their fifth or sixth decade, although life expectancy remains reduced compared to the general population. Importantly, frequent crises can lead to cumulative organ damage over time. This case highlights the need for a multidisciplinary approach to manage sickle cell disease, including medical, psychological, and social support to reduce morbidity and improve overall outcomes.